I'm Michael Moore. I'm the past president of the World Federation of Public Health Association, and now I have the privilege of chairing the International Task Force on Immunisation Policy. And it's in that capacity that we're looking at a call to action on HPV vaccination, human papillomavirus. One of the most important things that we're dealing in this call to action is to bring people with us, other NGOs, academics, so that we can deal with a really important disease that we can get rid of. Cervical cancer has been a blight for women around the world, and we know that this vaccine has a fantastic impact on that sort of disease. And we know it applies to other issues as well. But it looks like that we will be seeing the end of cervical cancer within the next few decades, is certainly in some countries, and hopefully in across the world in due time. Along with my colleague Bettina Borish, the CEO of the World Federation of Public Health Associations, we're very keen to ensure that as many people as possible can join our call to action, can play a part in ridding the world of cervical cancer and other drugs that are also related to the human papillomavirus.
Thank you, Michael, for introducing me. I'll do say some words about myself. I'm Bettina Borisch, a professor of public health in the Institute of Global Health at the University of Geneva. I am also the CEO of the World Federation of Public Health Associations. I'm definitely passionate about global health, public health, and how we all can live healthy together. But today, I have also to say that I had a first life, a first medical life that started behind the microscope. I'm a trained histopathologist and I have diagnosed mainly cancer. So, if it comes to cancer, I am quite another passion to see how we can prevent cancers and the suffering that goes with cancer.
It's very interesting that really, when we're thinking of vaccination for so many years, we've been thinking about pediatric vaccination. When we're talking about our children, most of us are very comfortable with ensuring that they don't get measles, that they don't get mumps, rubella, because we know the damaging effect that these sorts of diseases can have. And around the world, governments have focused particularly on having a schedule available so that we know when to have those injections for our babies, and to make sure through to 5-year-old in particular that they are what we then described as fully vaccinated. Well, we know that nobody was ever fully vaccinated because, as an example, if you scratch yourself badly, then you go and get a tetanus injection, no matter what your age was. And so there was an important issue about taking time to look and say, well, when does vaccination stop? And then, of course, we've had COVID, and we saw the number of lives, the tens of millions of lives that have been saved through the COVID vaccination. And it's comparable, of course, with flu vaccination. And they are vaccinations that we need to have throughout life. And the one that starts beyond pediatrics, the most important one, is the one for human papillomavirus, the HPV vaccination. The reason is because if we can ensure that that vaccination happens before people become sexually active, then the chances are very, very high that we can manage to ensure that the diseases associated with this vaccine, with its virus, with the human papillomavirus, can be reduced and eventually eliminated.
Well, I think Michael already said that in our minds, we were like, the children get vaccinated and then it's all over. We have to change this mindset. Um, Vaccination has no age limits. We have seen that for certain diseases, elderly people are more prone to diseases. We also know that through the life course, certain vaccinations have to be redone or reboosted. So it's a whole mindset to get vaccination out of the whole pediatric area into a life course immunization. And this holds particularly true for HPV vaccination. HPV vaccination is not a baby small childhood vaccination. It starts with young adults, girls and boys, and then it has, in fact, no age limit because the circulation of the virus, mainly done through sexual intercourse, will not stop at age 25 or 30. It goes on. And given the number of different strains, the possibilities that we reinfect ourselves with other strains is always there. It's important that we all together get the message through. It's a lifelong question. HPV will be around from young age to higher age.
Well, some people, of course, argue, look, I've had HPV, so I've had the infection, I've got over it, and that's brilliant. And that certainly does provide some protection. But there are different strains of the human papillomavirus, and with that in mind, it's incredibly important to ensure that you're protected against the full range of viruses that are treated by this vaccination, and I think that will help establish herd immunity. And the more people who are vaccinated, that means the more people who are vaccinated, the less likely the spread of the disease. And so that there will be some people who, for different reasons, won't be able to be vaccinated or cannot be. And with that in mind, it's important that we do get to the stage of herd immunity. So it's not only protecting ourselves, which is incredibly important, of course, but also those around us, and particularly true of the way we apply this vaccination to right across the range of adults who are vulnerable. One of the things that governments have tended to do is to say, actually, we've got only a certain budget, as governments do, and who are the key group that we need to vaccinate with this vaccine, the HPV vaccine. And of course, the obvious answer is adolescent women, and that's where they've started. Some governments have then not moved on. If you'd had enough budget, you would have vaccinated to start off with. You wouldn't make a distinction between girls and boys, men and women. You would simply vaccinate. And remember, this vaccine has not been around a very long time, and in more recent times, different countries. So it's not surprising that 25-year-old, 30-year-olds have not had the opportunity to have this vaccine. And it's important to ensure the broadest possible use. And that's why governments really should consider, first of all, ensuring that as a priority, young women, then women through to age where they're sexually active, and then also to men. So I think there is a hierarchy here. The ideal is that you are vaccinating anybody who's not been vaccinated who's sexually active. When we talk about men being vaccinated with HPV, the thinking generally goes, oh, well, this will protect women better. But we forget that men also, from the human papillomavirus, wind up with throat cancers, with penile cancers. And interestingly enough, a number of research papers have shown that when men are affected, the impact on them is often much greater. They're more likely to not only have a greater morbidity issues, but also mortality. So, in other words, they're going to be both sicker and die more quickly than women. That's early research, but it actually says, look, it's important for men as it is for women. I think the most important part is taking action to get rid of the virus. And the more action we can take to get rid of this virus, the more likely we are to be successful in actually eliminating the disease in a way we do with smallpox, in the way that we are very, very close to doing with polio.
There have been proposals to go to so-called groups at risk, but a generally distributed infectious agent will also go beyond risk groups. And it's very difficult to talk about risk groups or high risk groups in viruses because HPV is a large family of viruses that are so common and so widespread among human beings. So that it is more difficult to find an adult human being that has no contact to HPV than the ones that carry one or the other of the substrains. So the idea that we will do good by vaccinating only subgroups is erroneous.
Look, once we try and target girls, once we try and target boys, once we go, step by step, the downside is that we're not going to be able to stop the circulation of the virus. So what we're really trying to do is stop the circulation of the virus. And it would be easy to say, well, let's just make sure that people don't have more than one sexual partner. We've found internationally with a whole range of issues that that doesn't work. And therefore, let's be really practical and find out what does work. And what does work is the vaccination right across the community and to stop the circulation of the virus. That's the key element that we're talking about. Our Australian Broadcasting Commission only a few hours ago has circulated that we have had zero in Australia. There have been zero cervical cancer diagnosed in Australian women aged under 25 in 2021, the first time since records began in 1982. Zero. And it shows that if you can stop the circulation of the virus, that work. The countries of Australia and Sweden are well ahead in broad vaccination, and already the results are showing a really, really good outcomes.
Yeah, we can only thank these countries. I think of Sweden, who clearly put that high on the political agenda to be one of the first countries to have eliminated HPV in the country. And they show that it's possible. They have shown that by using a full population, both gender and ages strategy, you will reach the goal very fast. Whereas other models, mathematical models that use risk groups or only parts of population will show us that it's more costly and prolongs the circulation of the virus. So what we can learn from countries such as Sweden is that you really go for it. Vaccinate throughout the life course and all genders. You will very quickly or quicklier come to eliminate HPV in a given population. And this is a good learning, and it's a good kind of pilot study that these countries have done for all of us.
In low and middle income countries, vaccination is always hugely challenging. And it's understandable that they put their budget priorities in different ways than in more developed countries. So I think the challenge there, particularly because the virus is often spreading even more than in other countries, thanks to vaccination starting earlier, is to go through the process to seek funding from the sources outside the country, but also to use your own funding because in the end, investment now is going to save you a lot more money. Treating cervical cancer is extraordinarily expensive. So, like all vaccinations, the return on investment is the thing that our low and middle income countries ought to be looking at. It's certainly the thing that developed countries have been looking at. The return on investment is well worthwhile. And so that's really the challenge. The difficulty for those making the decision is the money goes out now and the return usually doesn't come in the next 10 years, and certainly not in the years of a political cycle where somebody can get the credit for the implementation of the vaccination in a universal sense, making sure that it starts with yes, young women, but preferably young women and young men, and then goes through in, I guess, age groups to those who are most sexually active.
I think here you really touch on something very serious. It's the issue of equity and human dignity. And at Global Health, we cannot display all our good inventions and innovations to those who already have a good healthcare system, who already are good taken care of, and neglect those who have the highest burden of disease. Cervical cancer is a cause of disease for young women in a lot of so-called low-income countries. But it's no longer an issue, for example, Switzerland or Sweden. The number of cases is low, and the number of people dying is extremely low. In addition to that, there are other cancers. Let us think of oral cancer linked to HPV, prevalent in Asian countries, that create a lot of suffering. So just on moral basis, we cannot vaccinate in the well-off countries where there is a low case burden and neglect the countries where the diseases linked to HPV, such as oral cancer, cervical cancer, penile cancer, are a real risk for the life of people. So the question is always financing. Again, I think financing and prices is something that has to be debated and decided. The price is something that can be negotiated. And we see a lot of development with the production of vaccines. We have several companies that produce the vaccine nowadays, and we know that governments can negotiate prices of vaccines accordingly. And I think that also the companies producing are very open to these negotiations. And that's why I always think that coming up with, yes, but we don't have money, is perhaps not the right take on it. We have to start with the idea we will vaccinate those most in need. How can we manage? That's the way around.
Look, generally, with vaccination, that's right. Well, we look as where the broadest possible ways we can vaccinate, and we look at, of course, medical practitioners. We look at pharmacies, workplaces. We look at community settings. But with HPV, in the initial instance, the most effective spot is in schools. And certainly Australia's experience of vaccinating in schools has been extraordinarily impactful. That's been the single most important factor. And then having the backups with the general practice, with pharmacies, community, local councils, all of those things that are normal backups, if you like, for other vaccines as well. But number one step is schools prior to normal sexual activity, boys and girls. Yeah, look, the epidemiology is really clear on this that we ought not be thinking of vaccinations as being cut off at a certain age. Now, governments make decisions about what they fund and what they don't fund and when they fund things, and they will look statistically, and that's what epidemiology is, largely statistics, about the most impact of a disease. So, in with regard to flu, they'll tend to support older groups first. Because this is where you get the greatest level of sickness, hospitalisation, and death. With regard to HPV, the most important priority go well beyond children, and then think about where are you going to get the best return on your investment. And the best return on the investment, as I said, was to start in schools, to continue then through the ages where people are going to be sexually active. I think there's been a very interesting language issue around gender, and it largely stems out of the MAGA movement in the United States, President Trump and the Health Secretary Robert Kennedy Jr. The folk who are going, look, we shouldn't be using the term gender. Uh, and look, that probably has an impact on most people. Personally, I'm very comfortable with the term, but we still do want to bring as many people with us as we possibly can. So when you're then talking about universal vaccination, you're talking about vaccinating everybody. And with HPV, you can have age-related universal vaccination, because in the end, what we're trying to do, as I hope I've emphasised, is stop the circulation of the virus. If we can stop, if we even slow down the circulation of the virus, has a major impact. If we can stop the circulation of the virus, then we're really making great grounds. And we believe there will actually be no endemic cervical cancer in Australia in the next 5 years. Actually, I'm told even less than 5 years. And the fact that we haven't even had a case since 2021 is also uh, a very influential factor in the way people should think about universal vaccination and and maintaining that language of being inclusive, that we're going to that we should be vaccinating everybody uh, to stop the circulation of this horrible virus.
Yeah, that's a good one, a very good one, because that's where we struggle in public health very frequently. The language, and particularly around vaccination, where we have now, especially following COVID, a lot of vaccine hesitancy for a number of vaccines. We have critical positions that will very clearly look at the wording we use. And for some, we had internal discussions. For some, the word gender is not good. For others, gender positive is not good. For the moment, I think universal sounds quite acceptable to a broad community, universal vaccination. And that's what it is, because we have a universal distribution of the agent of the different human papilloma viruses. So let us pay attention to the language we use. It may be different from region to region of the world, and the cultural differences, as we say, cultural, should be always respected. But in general, we have to come to a strategy that helps governments, agencies to get a universal vaccination throughout ages and gender. I say it here. Maybe that you have to find other wordings in other places, but for the moment being, I think that's the best wording we can have in our call to action. vaccinate everyone. If we think of vaccines for other infectious agents, we would never have started to say we only vaccinate women, because we know it concerns everyone. So let us use the language that has been used in vaccination for other agents and say it circulates in the population, it concerns all of us together, and we can only live healthy all together. So that means we also protect others by being vaccinated ourselves.
Thank you so much for the opportunity to talk about how we're going to stop the circulation of this virus, and in doing so, prevent, most importantly, cervical cancer, but also those other cancers that are caused by the human papillomavirus, including penile cancer, throat cancer, and a range of others. We have an opportunity, really an opportunity like we haven't had for many years with many diseases. We've had the opportunity with smallpox. We were successful. We've had the opportunity with polio. We are almost there, only 39 cases up to November this year of endemic polio, and those restricted to just two countries, Pakistan and Afghanistan, and in a remote area on the border. We're very, very close to getting rid of that disease. We may even be closer to getting rid of this human papillomavirus caused diseases, following very, very quickly from those. We have an opportunity here. It's one that really has to be taken seriously. And what we need is to have people in NGOs to academics and just those interested to support this call to action, to make sure that governments understand that an investment now in universal vaccination of HPV is going to have a very beneficial return for the community as a whole, not just measured in terms of pain and suffering, but also measured in hard financial terms.
What I would like to add is, you all remember perhaps that the discovery of the link of human papillomavirus and cancer gave Harald Zuhausen in Heidelberg, DKFZ, the Nobel Prize for Medicine. This means it was really an important discovery to be able to get the burden of the disease and the suffering from cancers, several cancers, away of humankind by vaccinating. So I think we should not leave this opportunity that we have to get rid of cancers, a certain type of cancers, by vaccination. It is such an opportunity. It is such an opportunity we should not miss. Thank you.